Welcome back to our Health Technology Assessment course. This is video 10, and in this video we will show you an example of a systematic literature review. So the literature review was done in the field of hypertrophic and also dilated cardiomyopathies. And as you all know, the disease burden of both type of diseases can be very high because patients have to go regular screening. They might also undergo genetic testing. They have a higher mortality and also some treatments like, for example, implantable cardioverter defibrillators, or in an end stage, the ventricular assist devices might also be necessary. These treatments are of course very expensive and also invasive. So these treatments can also increase the economic burden. So it's a burden for the patient, but also for the whole society. And also the patients are often sick or unable to work. And this is also why we have a lot of productivity losses here in these two diseases. And what is also, especially in HCM and DCM, often the case, that also young people are affected. Then further, next to the disease burden and the economic burden, the disease also puts a psychosocial burden on patients, because patients have to deal with an increased risk of sudden cardiac death, or the disease progression, or the potential inheritability of the disease, and they might undergo lifestyle changes and face anxieties and also insecurities. So it is assumed that the burden of disease is very high. But there are only a few studies really examining the burden of the disease, and there's also no overview yet about the about the burden of disease and studies examining them. So we need an overview. And why? Because an overview facilitates the healthcare decision making when you have one overview with all available evidence, and it also unravels important knowledge gaps and can guide future research. And of course, you can, with an overview, raise the awareness about the disease burden and then really prove that there is a high disease burden. So the aim of this systematic literature review was to search for economic evaluations and cost of illness studies in inherited cardiomyopathies, with a special focus on hypertrophic and also dilated cardiomyopathy. So it was a systematic literature review. This means that not only one, but 5 databases were used for the search, and we searched in Medline, Embase, NHS-EED, EconLit, and Web of Science. The search strategy was inserted at the 28th April 2021, and we included all studies that were published after 2010 in the review. So first of all, we scanned then the study according to the title and abstract, and then if it's still eligible, then we further continued with a full text analysis, and of eligible studies we also did a reference checking. The final selection of studies and also the quality assessment was performed jointly, so by at least 2 independent researchers. And for the quality assessment of the eligible studies, the Consensus on Health Economic Criteria list, the checklist, was used. And so we were able to calculate quality scores for each eligible study based on the assessment of the study characteristics, but also the methods and the reporting was assessed. Further, costs reported in the studies were adjusted to inflation and currency, and we expressed all costs in 2020 euros. This is an overview of the research done in the systematic review, the so-called PRISMA flowchart. And you can see here in this overview that after inserting the search strategy, that at the beginning we had a total of over 3,000 studies that we found or that were identified, and then we screened them according to title, abstract, and also full text. And in the end we had 13 eligible studies, 2 cost of illness studies, and 11 economic evaluations. So the results of the studies we found was that we have 11 economic evaluations, 5 in HCM and 4 in DCM, and 2 have been trial-based economic evaluations, including both types of the disease. Then we saw that we have 4 economic evaluation in different diagnostic measures. So as you can hear, 1 follow-up care program for relatives at risk of having the disease, and 3 studies in genetic testing. Further, we identified 7 studies in different treatments, like 1 in an automated external defibrillator, 1 a variable cardioverter defibrillator, 3 studies in an implemented cardioverter defibrillator, and 2 studies dealing with ventricular assist devices. The majority of studies was performed in the US, but there have been also studies performed in Australia, and then the UK, Sweden, the Netherlands, and Japan have been each 1 study. The societal perspective have been chosen in 5 studies. Regarding cost of illness studies, we only identified 2 studies, and they are both in the field of hypertrophic cardiomyopathy. And both studies had the same approach, namely a top-down approach in the US. The quality assessment, so after going through the checklist, we assessed each eligible study according to different measures, and we saw that the economic evaluations, which we identified, have been or they all had a very good quality. So overall the score is very high with 86.6%. However, the cost of illness studies, they have been lacking in their methodology they used. And the main issues have been why the studies were lower or were reduced in their quality was the studies often did not include all relevant costs, and also not all studies included the quality of life aspects. So on this slide you can see the cost effectiveness plane, which visualizes the results of economic evaluations. And again, you can see on the x-axis the incremental effects, and on the y-axis the incremental costs. And in this plane we included 2 willingness to pay thresholds, a 50,000 per quality gained and a 100,000 per quality gained threshold, seen here in the lines. And interesting to see here is that in treatments in DCM, that most of them have been above both thresholds, and that would mean that they are not cost effective. When we look at treatments in HCM, we see that they are mostly located underneath the thresholds, and 2 are even in the lower quadrant, meaning that they would be the dominant strategy. But that doesn't mean that all treatments are cost effective only in HCM, so we have to look into each study in more detail, so which subgroup was analyzed, and we need some more background information here. And let's start with the diagnostics. So there were studies about genetic testing versus regular screening, and here we saw that the results, so the ICER was far below the willingness to pay threshold. So here the result is that genetic testing is highly cost effective, and we saw that in both, so in hypertrophic but also in dilated cardiomyopathy. Then there was 1 study dealing with a follow-up care program for relatives at risk by a genetic counselor versus a cardiologist. This was a trial-based analysis from the Netherlands, conducted in the Netherlands, and here they calculated no ICER. That was missing in this study. However, the conclusion was here that the follow-up care program was well appreciated at low costs and should be also considered as a good alternative. Then regarding the treatments, there was 1 study about the automated external defibrillators versus none, and this study was conducted in a pediatric HCM cohort, and here the result was also that the use is cost effective in children not eligible for an ICD placement, and the QALY was below the 100,000 per QALY gained threshold. Then we had 1 study dealing with home variable cardioverter defibrillators versus none, And also here, a pediatric cohort was analyzed, this time in DCM, and these children had a high risk of sudden cardiac death. And also here the ICER is very low, so here the recommendation was that the use of VCDs is cost effective as a bridging strategy in children waiting for an ICD placement. Let's go further. So we also had studies dealing with implemented cardioverter defibrillators versus none. And we had some studies in HCM, but also one study in DCM. And here the result was very different, because in HCM we saw that it is highly cost effective and even a dominant strategy. But here the focus was also on children and adults at high risk of sudden cardiac death. And in the study of about DCM, we saw that the ICD placement was considered not cost effective and is also not recommended. But here the focus were on children with DCM but mildly symptomatic heart failure. So the last type of treatment we identified in our review have been ventricular assist devices versus watchful waiting. And here the results have been also a bit different. So at an end stage, also again in children with DCM, ventricular assist devices are not regarded as cost effective as a bridging strategy. However, in the other study, which was a trial-based study, we saw that ventricular assist devices can be regarded as a cost-effective alternative or cost-effective strategy, but only when you consider a longer time frame. So overall, here you can see again an overview of the studies we identified. So we identified different interventions, and again the subgroups were a lot of times different. So sometimes HCM was addressed, sometimes DCM, sometimes an adult population, children. So a lot of different subgroups were addressed here. And we can see that per subgroups only limited evidence is available, and sometimes even no study was conducted. Regarding the cost of illness studies, we only identified 2, both in the field of hypertrophic cardiomyopathy and one with a special attention on obstructive hypertrophic cardiomyopathy. And both measured the cost from a top-down approach with an insurance database, and both were conducted in the US. And here in both studies also only the hospitalization costs were considered. So in this case it's very difficult to interpret the hospitalization costs because we have no comparison here. So the end conclusion would be, or the conclusion that we can draw out of our systematic literature review, is that there is a huge literature gap. So we saw that in the economic evaluations there are some available, but the evidence per subgroup is limited, and the literature gap is even higher when we look at the cost of illness studies. So to come to an end, here's some take-home messages from our systematic literature review. So very little research about the economic consequences was conducted in the last decades in HCM and DCM. In DCM even less. And the cost effective strongly relies on the targeted patient population, but evidence per subgroup is limited. So more studies are needed to confirm the results of the available economic evaluations. And the transferability of the results is also questionable, because we saw a lot of studies were conducted in the US or Australia. So it's hard to say if it's really 100% transferable to other countries, like for example the Netherlands. So future studies are needed, also in a Dutch setting, for example, and these studies need to include broader costs and also the quality-adjusted life years as an outcome, and this is the recommendation. So all studies which we identified in the review are of course listed in the course manual, and then I would like to thank you for listening.